Alright, so today's training we're going to be talking about co-occurring disorders as well as how that fits into the High Point treatment model as well as the services that we provide as an agency. So the training was put together by a couple agencies that also do a lot with co-occurring disorders. NADAC, Orion, Westbridge, and Hazleton are very well known nationally in terms of their treatment coordination and models for treating co-occurring. So all the material today came from those sources to bring for you guys. So today's training objectives, we're going to be reviewing the prevalence of co-occurring disorders in substance use programs, the contrast between co-occurring treatment and traditional addiction treatment, as well as giving the rationale and explaining why we've moved towards a more integrated model for our clients. Also looking at specific instruments that you guys may see in terms of the programs you're working in, and describing other evidence-based practices. It's good to have the knowledge of what the system offers as an agency, so when you hear acronyms and names throw out, you know exactly what different disciplines are doing. So according to SAMHSA's 2014 National Survey on Drug and Alcohol Use, 43.6 million Americans aged 18 and older experience some form of mental illness. When they further broke down that data in the past year, 20.2 million adults had a substance use disorder as well. So of that, when you think about the numbers, 7.9 million people in our nation had both a mental health and a substance use disorder diagnosis. So this is what we call co-occurring. It's when someone has both a diagnosable mental health concern as well as a substance use disorder. Most of the people that we see come through our doors probably have more co-occurring than just, I'm just addiction, I'm just mental health. So knowing how to treat both because of the prevalence is really important. So 50 to 75% of all clients who are receiving some kind of treatment for substance use also have another diagnosable mental health disorder. Some of the more common ones you guys may hear thrown out are anxiety, depression, PTSD. Of all the psychiatric clients out there who have a mental health disorder, 25 to 50% of them also currently have or have had a substance use disorder. So our more psychiatric population, schizophrenia, bipolar, have also had experience with substance use in one form or another. So we call this comorbidity as well as co-occurring when we have both a psychiatric disorder present as well as the substance use. So there was a national study done of about 10,000 adults, and 13.5% of them had an alcohol use disorder, and 36.6% also had a psychiatric disorder. So there's a lot of treatment implications that go into why both, not just one or another, which we'll get later into in the presentation. 6.1% of them had a drug use disorder, and of those, 53.1% also had a psychiatric disorder, and then 22.5% had a psychiatric disorder, and of those, 28.9% also had alcohol or drug use. So with...
Excuse me, before you go, were you supposed to pass those out, or no? Okay.
So in terms of psychiatric disorders with addiction treatment, there were additional 2 studies done through a couple different agencies in addiction treatment settings, and they found similar findings. So it's not just one state, it's not just one study. There have been multiple reports coming out that these numbers are pretty close, so it's not just a Massachusetts issue, it's not just a Southeast issue that we deal with. It's something nationally that we're looking at in terms of integrated treatment throughout the country. And this is just another slide showing the data that came out around addiction treatment providers estimating by psychiatric disorder. So mood disorders account for about 40% of the population that we see come through our doors for treatment. That includes your depression, your bipolar disorders. Also looking at anxiety, around 25% of the people coming in. Post-traumatic stress or PTSD is also around there. Antisocial personalities account for between 20 and 25, and then you add in severe mental illness at the bottom, which is your schizophrenia, psychotic disorders, really impaired functioning. So substance use disorders occur when the recurrent use of drug or alcohol causes clinical and functionally significant impairment. So it can be additional health problems the person may be experiencing, a disability, they can't go to work, they can't get out of their house, they can't go to school. They're not functioning in other areas of their life as a result of the substance use disorder and as a result of the mental health condition. So the DSM-5 came out, and a diagnosis of substance use disorder is based on evidence of impaired control, social impairment, as well as criteria meeting dependence or withdrawal criteria. So when you have someone with the coexistence of both a mental health and a substance use disorder, this is what your providers will refer to as co-occurring. So these are often placed on a continuum based on the severity of the symptoms as well as the impact in the functioning. So a non-severe case may be early off in the continuum, just started using, kind of mild depression, mild anxiety, an adjustment disorder to a life stressor, or some kind of personality disorder. When we get into the more severe categories, these are individuals that may be diagnosed with bipolar disorder, schizophrenia, schizoaffective, major depression. They may have had hospitalizations as a result of their mental illness, but also when we're thinking about co-occurring, how is the substance use playing a role in that? So diagnostically, what usually happens is providers will try to attempt to determine what came first, chicken or egg. The mental health came first or the substance use. Comorbidity, we would treat both as an integrated model at the same time, but it's helpful diagnostically when providers start talking about, were you depressed before you started using, or did your depression come after you started using? So that really helps in terms of driving treatment and interventions that we can offer to people. So in terms of quadrants of care, this is a nice model when we think about severity. So when you think of someone being low, this is in terms of low substance use severity, they're not needing detox, they're not in withdrawal, and also low mental health disorder severity. They've not been hospitalized, some mild anxiety, mild depression. As you go through the quadrants up to 4 and 3, these are the higher areas where you see the more chronic population coming through. For any of you that are going to be working in our inpatient treatment programs, majority of clients that you will see will be in quadrant 3 or 4. Community-based providers, outpatient, more so around the 1 and 2 range. So what is co-occurring and how is it different from traditional addiction treatment? So models of care have historically been kind of removing the substance use treatment from the mental health treatment. So someone may have gone historically to an agency and said, I'm depressed, and they receive mental health treatment, but the minute they bring up addiction, the agency says, well, we don't treat addiction, we're going to refer you out to another provider. So separating treatment has not been the best in clinical care. More agencies are moving in a way towards an integrated model. So research has shown when you treat both simultaneously with the same treatment team, same providers, and they have an understanding of both the co-occurring piece and how to treat them, the client actually gets better care. Because it's not then trying to tease out, today we're going to talk about your depression, today we're going to talk about your addiction. Because a lot of times there are overlapping symptoms that go with it. So some of the old traditional more models of care out there are the single model that you go to a primary disorder, whether mental health or substance use, and you seek a provider based on that. There's also what's called a sequential model of treatment that acknowledges there is a co-occurring issue, but they also treat one at a time, so focusing each session as we're going to treat this first and then the next. Parallel model, you may be experiencing treatment at the same time, but you're getting it from separate professionals, separate agencies, 2 different sets of teams. The integrated model is what High Point really strives to do in terms of treating co-occurring disorders that utilize one competent treatment team at the same facility, and they address all mental health and substance use concerns at the same time. So the integrated model of care, when you hear providers talk about it, it's best defined by 7 components. The first one is integration, comprehensiveness, assertiveness, reduction in negative consequences, long-term perspective, motivation-based treatment, and multiple modalities. So when we talk about integration of care, this is nice because it reduces the need for multiple providers calling other providers to find out what's going on. It also has reduced frustration for clients, that they don't have to remember 2 appointments a week. What did I tell this therapist that I have to tell this therapist? They're not retelling their story multiple times as well when they're doing an intake process. That can be stressful for clients, especially if they're in a help-seeking mode. Shared decision-making. So the client is an active part of their treatment, but also the treatment team is available to be a part of that in every aspect of care. So it's not just the team telling the client what to do, it's everybody working together. Families and significant others are typically included more with integrated care. Clients have the right to say who they want involved, but when you have all the providers treating at one location, it's better able to have family sessions with the doctor, with the clinician, be more integrated in terms of that. Family support, social support has been found to increase treatment outcomes, so having that as a better ability to do so helps the client in the long run. Transparent practices also help with what we call shared responsibility. So the clinician is aware of what the doctor is doing, the doctor is aware of what the clinician's doing, everybody's on board with what the client is doing. So really that transparency of honesty, everyone is involved, everyone's an active part of treatment, helps outcomes as well. Clients are then not able to go to one therapist and tell them one version, go to another provider at another agency, tell them a different version, and then now you're having to have those providers talk to each other. Clients also become more empowered to treat their own illness and manage their recovery because the responsibility goes on them in order to make the changes and the positive steps. The treatment team there is guiding them and giving them positive feedback, how can we help you, but it's also empowering them that they're getting all their needs met in one place. And then also the choices in terms of treatment, more ability to self-manage and higher satisfaction and care. So when the family's involved, when the client is involved, if they have the option to get everything under one roof, it's really giving them the person to guide their treatment. So integrated care also assumes that one disorder does not necessarily become primary, and there isn't necessarily a causal relationship between them. So we don't automatically assume that the alcohol is because of the depression or the depression is because of the alcohol. We treat them as two separate entities, but knowing that one does affect the other. We don't just assume one is going to actually cause another. The other thing with co-occurring is brain diseases, they need to be treated simultaneously, so the medical piece. What has happened to functioning, what has happened to them medically, treating the whole person. You can't just treat the behavioral health, you can't just treat the substance use without addressing every aspect of the person as a whole.
So do you include chronic pain patients with them?
We do see quite a bit of chronic pain patients that come through that have mental health concerns as a result of managing their pain or have become addicted to the medication that has
Right.
been prescribed for the pain.
Right.
So seeing those patients, we talk to them about what are the goals that they're looking to do in terms of treatment, what are the outcomes they're hoping to manage. Sometimes we can manage it internally with some of the options we have, but then it also comes around with the coordination with outpatient services, also looking at pain management programs. So really that coordination piece becomes more important with the medical side,
Yeah.
but a lot of patients will come in and say they've had a history of chronic pain or injury or surgery, and this is how they ended up at our door. So we try to treat all aspects. Same thing with individuals with like diabetes,
Yeah.
high blood pressure, hepatitis. Those are gonna negatively impact how someone's feeling about themselves, so we try to get all the providers on board, get releases, and do the coordination to ensure that every piece of the person is being treated.
Thank you.
Yeah. In terms of screening and assessment, when someone walks in our door, regardless of what program you're working in, what level of care, the screening process is where the client gets evaluated for what the issue is, what's the most appropriate program for them, can we treat them in the program that they're asking to be treated, but also trying to tease out and identify what those issues are gonna be. The assessment piece comes in secondarily, where they're actually sitting in front of you, engaging in an interview, telling their story, this is where I was, this is where I am, this is where I wanna be, and then determining based on what they're saying, what the most appropriate interventions are gonna be moving forward. The complexity with co-occurring disorder comes in more around the physical piece. So if someone's coming in intoxicated, really trying to tease out what level of intoxication they're at, can I get an accurate history? The risk for withdrawal, are they using enough substances that they may need a medical detox? Are they safe to do it at home? Also substance use induced mood disorders. Are these as a result of the substance use, the withdrawal, the process that they're going through? Motivational factors, why does the client want to be here? A lot of times we hear clients say, my family wants me to get help, I really want to change. Other times we hear, I was referred by DCF or probation. So really determining why the client wants to be here and what we can provide are important factors in choosing an appropriate treatment model. Also their feelings, their symptoms, and the other disorders they may say they've walked in the door with. If 5 other providers have diagnosed them with alphabet soup and they come in rattling off every diagnosis they've had, teasing out which ones really are playing a part in what's going on and prioritizing that with them. So substances can typically lead to negative emotions with the client. Depending on what the client's using, the substance will have an impact on their mood. Some substances help someone feel happier and euphoric and better. Other substances can cause you to be depressed and anxious. So that's also part of the diagnostic piece, is teasing out what substance they're using, but having an understanding that if it's alcohol or benzos, those may lead to someone being more depressed and anxious versus if they come in saying I'm using marijuana or I'm using hallucinogens, they get a different feeling with it. So trying to figure out, is it related to the substance? Is it related to actually something more mental health going on underneath? And then the choice of how we screen clients usually depends on the professional. So an outpatient clinician may screen differently than an RS at a program or a nurse or someone on inpatient. Also the cost of screening materials. Utilizing tools that are evidence-based, which means they've been tested over and over again and they work well, but also figuring out, is this an appropriate screening tool for the client based on insurance and medical need? Also, how simple the scale is to interpret. Sometimes clients come in with very little education. Asking them to read something and fill it out may not be an option, but then also the skill of the clinician to interpret some of those more difficult psychometric things. So the agency works hard to choose scales that are easy to administer, are easy for our clients to understand in terms of education level, typically who we see, but then also easy enough to interpret that you don't need someone with a PhD to do so. Also looking at the psychometric qualities, this is how reliable is it? Is it going to give me the results I'm looking for? We want to use tools that are going to be good in terms of, am I getting the information that I need, not just because it's a tool out there. We also look at the relevance of screening prevalent to the disorder. So are there tools that work well with both mental health and substance use? Are there tools that are just for substance use or just mental health? So trying to choose the ones that are appropriate to that client at that moment as well. And then also moving away from the sensitive measures to just keeping things very specific and general. So the integrated assessment process usually is done in 12 steps. So the first step when the client walks in the door, regardless of what program you're in, is to engage them. Develop rapport, talk to them about what's going on so that they feel comfortable enough opening up and discussing it with you. The next step is identifying and contacting collaterals. We always work hard to try to get releases for family, friends, peer supports, primary care doctor, previous treatment, anyone the client is comfortable with us contacting to get additional history, information, even to corroborate information. That can help strengthen how we treat the client and get the information to other providers on the team. Screening for and detecting the co-occurring disorder. So administering the tools that High Point has offered within our medical record and seeing where the client is at in that moment. Also determining that quadrant or locus of responsibility, so that severity scale of 1, 2, 3, 4, is what they're asking for the most appropriate course of treatment? Do they need more treatment? Do they need less intensive treatment? And then also, where is the client's motivational factors in accepting that help? Determining level of care comes out of, is the client safe to be in this program and can this program meet their needs? If someone is in active withdrawal and at medical risk, being out in the community with a CSP worker may not be the appropriate choice at the moment. They need a detox. If someone is saying, I've only used once, really do they need to be inpatient for 7 days? So really, as a clinical person, teasing out, is this the most appropriate treatment? For some of the programs, the screening has been done for us as an agency. The person has gone to an emergency room or a crisis team has said, this is what we think. But someone walking in off the street can also get that same assessment to determine what are the services that are going to help them in that moment. And then determining diagnosis. So this is where providers will try to figure out exactly what's going on, give a best idea of what the diagnosis will be, starting treatment, and then initiating treatment options based on that diagnosis. Diagnosis is ever changing. It may change a couple times based on if the client's symptoms improve, as their mood improves, and then you gather more information. So that's like an ever-changing document that you will see get updated as the person starts to open up and we tease out what's going on. We also look at determining disability and functional impairment. Can the client work? Can they get to appointments? Are they isolating from friends? Are they doing healthy things they should be doing in the community? Realizing the functional impairment of what's going on, or if there is a disability, helps with treatment planning too, because they may need more assistance in some of those basic life functioning areas that we can provide other services to do. Identifying strengths and supports. So the biggest thing with integrated care is really focusing on client choice and client voice. The client is in the driver's seat of their treatment. We're not going to throw out an intervention, have the client say no, and then force it on them. We want to be a collaborative partner with our clients to make sure we're identifying the things they're good at, the strengths they have. Are they hardworking? Do they have supportive family? Relying on those strengths to then drive treatment and say, well, let's try these couple things. Are you in agreement with it? When you try to put an intervention for a client that they're just not feeling, or it's not within their realm of, I'm gonna be willing to do this, we're not giving them the choice in how they wanna improve themselves. Identifying cultural and linguistic needs. So this is huge within the population we serve. Clients may have language barriers that prevent them from seeking competent services. Culturally, are clients from a culture that does not accept mental health and substance use as treatable disorders? Do they look at it as a personal flaw? If you're sitting with a client who speaks only Spanish and you're speaking English, trying to use an interpreter, how comfortable are they to really open up? So trying to match those appropriate services and understanding their background, their ethnicity, their language barrier, really helps us to also drive treatment and develop more appropriate interventions. And then identifying problem domains, these are the things the clients want to work on. What are the primary goals they want to accomplish coming to treatment? And then developing a plan for treatment around what their identified needs are. Stages of change. Where is the client in terms of their level for motivation? This is a model used in most addiction treatment programs. It's a 5-step model. It helps to determine where is the client ready to make changes, where is the client maybe stuck, and at what phase of accepting treatment are they in.
This is what contemplation, pre-contemplation?
Yep, pre-contemplation, contemplation, action, maintenance, yep. And then working with the client so that they understand where they're at. So if you give them a diagram of, here's where your thinking is, and this is where you're kind of at the moment, this is where we move to the next phase, it helps them better understand kind of what are the things holding them up in terms of making those steps towards getting better. And then also planning treatment. So any program that a client is in, they either have a treatment plan or a service plan. And this helps to align the client's goals with what the treatment programs can offer. So they very clearly outline what the client is responsible for, what the provider is going to do to help them, the interventions that are being used. That way it helps to gauge treatment, that at intervals when it's evaluated, the client can say, I'm doing better because I've accomplished this, or I'm struggling because I can't quite get this. Ever-changing treatment. As the needs change, the plan changes, but it's always driven by what the client is willing and able to do. Yeah.
I think that you talked about this and somehow I missed it. What specifically do you mean by quadrant and locus of responsibility?
So the quadrant was the diagram earlier in the PowerPoint that showed the severity, either low, 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 high.
Oh, okay.
So based on their symptoms, impairment, we determine kind of where they're at.
Okay.
And if they're in the higher quadrants, that may mean inpatient treatment, that they need to be out of the community and somewhere to be monitored.
Okay.
The lower severity, kind of low, low, or low, high, they could probably do well with outpatient or other services.
Mhm.
So that helps us to figure out where they kind of fit in our continuum of care.
Yeah.
But the locus of responsibility also says, what is the client willing to do and take ownership of right now?
Okay.
Sometimes we can't necessarily force them into treatment,
Right.
so then that becomes a different discussion about options
Right.
of, do they need voluntary, involuntary, and where's their level of motivation at?
Okay, thanks.
You're welcome. And then in terms of developing level of care, this is something that's kind of thrown out. It's insurance company driven. They have certain criteria that clients need to meet in terms of being admitted to certain programs or continuing care. We follow it because most of our services are reimbursed by insurance, but we use it as a guideline. And it's a good tool to understand that when we're thinking about level of care, what are the needs that are being met? Because you always want to have the person in the most appropriate treatment program for them, not more restrictive or less restrictive than what they're able to do. And a lot of this is based on medical need, safety concerns, and where the client is able to access services. So in terms of that, the American Society of Addiction Medicine developed certain criteria that we call ASAM criteria in determining addiction comorbid treatment. And it's broken up into 6 dimensions. So those of you working in programs that you'll be using the treatment plan, we use these 6 dimensions in order to help develop the plan with the client. And it's a nice way to break out in terms of their acute intoxication, do they need detox? Any biomedical, do they have hepatitis or diabetes that needs to be addressed? The mental health, are we treating anxiety, depression, PTSD? The readiness to change, where are they in terms of their stages of change? Where are they willing to start to address the addiction piece? Relapse, continued use. Do they need a recovery plan? Do they need help developing a sober network of supports? And then recovery living. Do they need help getting benefits? Do they need insurance, housing, transportation? So really, all the needs that a person may have are broken up into these 6 categories, and we develop a plan based on what needs we're gonna be meeting with the client during our sessions. So typically, level 1 treatment would be outpatient. So any of our outpatient clinics doing one-to-one counseling, meeting with a doctor to do medication management. We also do some kind of medication-assisted therapy for those battling addiction around managing cravings, relapse, risk. So some of the services within High Point that you may hear with the acronym SOUP is RSS or CSP, which is a community-based caseworker helping the client walk through and navigate the system. Medication-assisted may be Vivitrol, methadone, or Suboxone. Traditional counseling can be done at any of our outpatient sites, and ACRA services is specifically for adolescents and young adults using substances. Level 2, we think about they may need more than just a once-a-week appointment with someone, so these are more intensive outpatient treatment services, partial hospitalization, SOAP day program, where they go every day, a few hours a day to touch base with somebody and get more intensive treatment. It can also include our in-home therapy team and community-based child health initiative services like a therapeutic mentor or an in-home therapist. Level 3 is typically moving up in terms of medical need, so it may be considered residential or medically monitored intervention. So some of the programs High Point offers would be our Castle program in Brockton for adolescents with substance use concerns, also our transitional support services, TSS, clients moving on in our system trying to get into halfway house or sober house, and clinical stabilization, which is CSS, which are attached to most of our detoxes. And then level 4 is the more medically managed intensive inpatient treatment. So these are the clients who are not doing well in the community, really can't notice an improvement in their symptoms unless they go that route first. So this would be inpatient psychiatric services here in Middleborough, dual diagnosis unit in Plymouth, also looking at our detox programs that they need a medically supervised taper to safely come off what they're using. So within High Point, we offer all these different levels of care and all of these services within the catchment areas that we serve. So helping a client determine what the most appropriate treatment is comes in with the clinicians and the nurses meeting with them saying, what are your needs, what are the areas we need to work on, and then appropriately referring within the system if we have the availability to do so. So also in most addiction treatment programs, there's 3 primary evidence-based practices that are used that you'll hear people throw around. Motivational enhancement therapy, you'll hear people talk about cognitive behavioral therapy, and then 12-step facilitation. So all of these models are used within our programs. We tailor these models based on what the client's level of motivation is, where the client is at in terms of their need for treatment. We can always use variations, but we leave it up to the client as to what their needs are. By addiction professionals around the country, and it can be easily applied to clients suffering from comorbid. So models of motivational enhancement for someone using substances can also be good for someone suffering depression. You don't just pick a model based on what's your diagnosis today. A lot of them do cross over very nicely. Integrated care also combines these therapy models and combines the 3 evidence-based practices into a stage-wise treatment model. So motivational enhancement can be used first to start the change process. Where is the client at? How do I motivate them to get to that next step? It can also help to develop a rapport and an alliance for the people you're working with. Cognitive behavioral is used to help them make the change. So when they've identified the thing they want to change, how do we put in cognitive behavioral approaches to get them to that change or assist them with starting that change process? And then also 12-step facilitation, getting them to that change, and then how do we sustain it long term? So really using the evidence-based practices to guide a client through treatment depending on where they're at in their plan. So these are your stages of change. For most clients, they're starting with the pre-contemplation where they have really no desire to change. They're happy with what they're doing. They may not be 100% okay with the situation, but they're not looking to make any big adjustment. Most clients will then move into this contemplation change where they're thinking about changing behavior, and most of the time that's where we get clients into treatment. They're thinking about it, they may have made a phone call, they want to get into a bed, I know I need to change but not exactly sure how to go about it. Clients can then move into this preparation and determination stage where they actually start to prepare and plan for the change. They might be going to a couple sessions of therapy, might have just got out of detox. What does my next step look like? They can then move into this action where they're engaged, they're motivated, they're working with their providers, they're making the changes they need to get better, and then moving into maintenance. And this is where they're sustaining the changes long-term. At any point in this continuum, a client can relapse. So they can be thinking about making that phone call, set that appointment, go use the next day and not show up. They can be in recovery for a significant amount of time, something happens, they relapse, then where do we go in the cycle? And the nice thing is people can move in and out of these stages pretty fluidly. It just depends on what is the intervention that the providers have to use to get them back on track. So the stages of change, we know we have to be where the client is. Our plan is not their plan. We have to accept the moment that they're in and work with them to guide them to that next step. So other considerations with co-occurring treatment, managing medications. So a lot of clients that come in with both a mental health and a substance use concern may ask to see a doctor to talk about medication options. So they can meet with one of our physicians and talk about, how do I manage my depression better? I think I need something. How do I manage my anxiety? I'm not sleeping. I'm having flashbacks. Treating the whole person then also becomes, if we treat the mental health, does that just consequently reduce their risk for relapse and their substance use? But also talking about medication-assisted therapies, Vivitrol for opiate and alcohol use, oral medications for management of alcohol cravings and relapse, methadone or Suboxone for our opiate-addicted clients. So really teasing out the medication piece and how they work together to meet the same common goal. Also involving family. Family intervention and integration of treatment is extremely important because without the support and people holding the client accountable, or the client being able to go and talk to their family, can also have treatment impact outcomes. Sometimes involving the family also repairs bridges. So are we repairing things that have led to the situation the client is in at the moment? And then also encouraging participation in peer support recovery programs. This could be your AA&A meetings, 12-step, SMART recovery. This could be going to the local church Bible study. So wherever the client is, what their belief system, kind of what their level of understanding is of our recovery environment, what does that plan look like in developing that positive support network? Yeah.
I have a question about methadone.
Mm-hmm.
I assume we have places or programs that provide methadone?
Yes, High Point does have a methadone program in Brockton.
It's in Brockton.
Yes.
And is it one that you have to go to at like 5 o'clock in the morning?
They do the daily dosing, so most methadone programs do start very early.
Okay.
They do have a treatment component where they meet with case management and do group counseling. It also depends on the area the client lives. So if we're working in a program in New Bedford, we can recommend our own methadone program, but if there's one up the street that's more accessible and closer, we want to make sure that we're giving the client the treatment program that's best for them.
Okay.
And usually that decision to do methadone or Suboxone or Vivitrol, the doctor can talk to the client about and determine based on their medical history, their risk history, what is the best option. But it also goes to some providers having a good understanding of what the management for the addiction piece is and not shaming the client for saying you need to be on something to stay sober.
Right.
It's accepting that's the place they're at in their recovery. How do we work with them and then eventually possibly talk about how do you do it without.
Yeah.
So it really adds another layer to
Right.
it, but we have clients that do very well on maintenance, that get them to that point, and other clients stay on it because they know that the risk is higher if they go off of it. So we do offer it in Brockton. A lot of clients will travel between the sites, but there are plenty of other agencies that offer it,
Okay.
and that's where the integrated care model comes in. You know, do you get a release for that program so you can talk back and forth and make sure the client's on track? So really that collateral coordination piece becomes extremely important in those cases.
Just trying to get a sense of what High Point has and where.
We do have resources, so when you guys do meet with your supervisors for additional, specific job training, we have brochures that most sites offer. There are forms, grids, kind of flow sheets that can be offered to say this is what is offered in our Taunton location, this is offered in Brockton, this is offered in New Bedford. So there are a lot of programs and it takes time to learn it, but then once you know what is offered within the agency, it really helps you become more informed of what you can offer with the client
Is
too.
all that on the intranet?
Most of it is, yes, and the supervisors do have information to say, if you're looking for this program, refer here.
Okay, thank you.
So collaboration with the prescriber is extremely important, even if they're just on a medicine for depression or anxiety. We want to make sure that even though the prescriber is the one who's ultimately kind of the high level of responsibility, that we're in discussion with them. If the client's not showing up for therapy, if we hear anything concerning, if we're seeing noticeable changes, opening that dialogue with the doctor to be able to say, you know, I don't think the client's doing quite well, or they discussed this in treatment, maybe you'd want to follow up with this at your next session. So really, with the addiction professionals, we tend to recognize a lot of those danger signs. If they're using drugs or alcohol and they're on psychotropic medication, we want to let the prescriber know, because that can be extremely dangerous. Also recognizing side effects, being aware that if they're saying, you know, I'm not feeling well, I'm having this or that we can let the prescriber know as well. And then also monitoring and supporting medication compliance. How do you keep your meds in a safe place? How do you make sure you take them every day at the same time? How do you make sure you have your refills on time so that you don't miss doses? Really doing that guiding piece with them. And then when you add the medication-assisted therapy on top of it, it's another layer of medication management, safety, and responsibility. So we help the client clinically walk through that piece because that's going to keep them stable. And then, like I just said, the managing the medication piece, the psychopharmacology can only work if medications are taken as prescribed. So if they're going to take it one day, not take it for a week, we're not going to see the outcome. So encouraging clients with co-occurring disorder that even though their symptoms improve, it's important they take it every day as prescribed. Also, clients sometimes have difficulty adhering to a dosing schedule. You know, are they going to take it once or twice a day, 3 times a day? Not taking meds can lead them to possible hospitalization because they can become unstable. So working with the client on systems. Do you set an alarm on your smartphone? Do you get someone in place to help remind you to take your medicine? So really teasing that out if the client has a history of struggling to be compliant with that piece. And then also clinicians helping to prepare clients to manage their meds. Some programs, the meds get administered to the clients, so doing that teaching piece of you take it, you know, like this every day. Nurses do that on the inpatient units. Sober houses, recovery homes help do that. And then in outpatient, we help to make sure, do you have enough of a refill? Are you taking it? Do you feel anything that you shouldn't be? And then involving the family in treatment is extremely important as well. There is a myth out there that people with co-occurring disorders are disconnected from their families. A lot of times they have some strong family support or family support willing to be a part of the active process. So trying to engage them in the process actually shows to have fewer relapses. More support also shows that disorders can be improved a lot more easily, plus there's that accountability piece and somebody also helping them. Unfortunately, a lot of family members of a client who has a co-occurring has experienced considerable stress, heartbreak, and confusion about understanding mental health and addiction. So some of them may have chosen to disengage because of the cycle of the person's illness. But coming into treatment is a great opportunity to try to say, let's bring family in and see what we can do to involve them to some degree and start mending that. Also involving family in treatment encourages the family member to develop a relationship as early as possible in the treatment process, so they're there from day one and can encourage the client as well. It also empowers the family to be involved in treatment, knowing that there are options for them. Do we say to a family member who's had a lot of stress or their own concerns with mental health or addiction, why don't we get you a separate provider while your loved one is here? What can we offer you to support you through this process? So really building that piece and giving them the education that there are support groups for them, options for them. What are the options for the loved one? Also encouraging families to attend self-help like Al-Anon or NAMI. Getting connected to providers and community agencies that can help with advocacy, understanding, and support also helps them better understand where the client is at in their treatment. So some of the support groups that are out there for dually diagnosed clients include the Double Trouble in Recovery meetings, Mental Illness Anonymous, dual diagnosers, dual recovery, smart recovery meetings. And this is where that self-help peer support comes in when working with a client. We want to make sure we're referring them to potentially community-based services that are helpful, but also that are going to focus their targeted needs. For some comorbid clients, going to a straight up AA or NA meeting may not be very comfortable because they're then thinking, what about my anxiety and my depression? Will people understand? Someone with comorbidity going to a regular NAMI meeting that's more mental health oriented may not feel 100% comfortable sharing about their addiction. So finding recovery meetings that meet that comorbid piece gives a better understanding that they're in a room with people who understand both struggles they're going through, but also getting the support and skills they need from those meetings. So a lot of these meetings are available on the websites. Smart Recovery has one. You can search by meeting day, time, area, town, and see what's available, and providing a client a list if they're willing to give it a try. It can be a great support for that maintenance long-term piece, because you're not going to see someone in therapy maybe 20 years, but if they develop a sober recovery network, maybe that becomes their treatment long-term to keep them going on the right path. So guiding principles of recovery, it always comes down to there are a lot of different pathways to getting healthy and staying healthy. Recovery is self-directed by the client, it's empowering, it involves personal recognition and a need for change and transformation. Recovery exists on a continuum of improved health and wellness, so a client can fall anywhere on that spectrum at any point in their life, but are they happy with where they're at and how can we help them strive for more change? Recovery also involves addressing discrimination and transcending shame and stigma associated with acknowledging the presence of a substance use disorder or a mental health disorder. And also recovery is supported by peers, allies, friends, family, and then joining them as part of that client's community. So getting them more involved with people who are going to be supportive and healthy of the steps that they're taking. And then also recovery can be a reality. So letting a client know that in that moment that they're asking for help, there is change and there is an option for sustainability with it. So do you guys have any questions? Yeah.
Just one, is any part of that PowerPoint presentation accessible on the computer or anything? It's just so well done and so well presented.
Thank you. All the trainings are going to be available on the intranet, so as you get to your job sites, if you need refreshers on any of them that you've had through New Hire, you can print out the PowerPoint. The videos are also there to be reviewed, and then every year there are the mandatory trainings, so you have to do a refresher to kind of get your brain going. Also, if you needed a copy of resources, you can ask your supervisor to print it off. So everything's on the intranet, and HR also has a copy. Any other questions? Well, thank you for your patience, guys. Have a good day.
What's your name?
Sarah. I work here at the outpatient program at Middleborough. I'm the program director.
So good.